with Danny Burke. I'm an intensivist at the Charlotte Hospital. I trained in internal medicine and GIM at the University of Sherbrooke. And I followed that up with a critical care fellowship, followed by a critical care ultrasound fellowship at Western University in London, Ontario. So I guess what drew me to intensive care medicine is just that it's like kind of the most intensive everything. So I was always kind of interested in, general practice, knowing a little bit about everything and all that. But really what is kind of the secret sauce of the intensive care is that you get a little bit of everything, but the most extreme, the most physiologically deranged, and that really interests in me. On top of the whole teamwork aspect, the human relations aspect. I guess a couple things. So patients are just so bloody sick. You get a lot of acute illness, but a lot of that acute illness is based off of chronic illness, which presents a pretty significant challenge when you're trying to care for these people. And then I guess part of the challenge that we're having going into this new era is just logistical constraints, personnel constraints, etc. So yeah, like you said, I also do some locums in smaller communities where you have a little less expertise, a little less technology to help you out. So a couple of things that you have to do to practice differently there is, well, one is you kind of have to know the difference between what's essential and what's nice to have, but not necessarily instrumental to being able to care for your patient. And then the other thing is that you need to be able to really exploit to the max the resources that you have. You're not always going to have extra bodies in the hospital be able to help you out. You're not always going to have that extra consultant that you can call when you have a question. So you have to be able to kind of figure things out as you go along and really, use different tools to try to be able to be at your best. So I got involved, a couple of years back, because it was an opportunity to try and help people that had been in positions that I had been in, where you're caring for these really sick patients. Minutes count. They're very sick, so a small mistake can have a greater effect on the patient. And developing a tool like Paratus kind of gives you the opportunity to, help people be at their best, to avoid those little mistakes, to gain those few seconds that can be the difference between a favorable outcome or an unfavorable outcome for our sickest patients. So I guess I have a few. So my focus is just one, making sure everything works within the application, that people are going to get the right information. Then part of that as well is building on the conditions. So not only having the right medications and the right way to administer them, but also knowing when is the right time to administer them, in what order. Helping people that are going to take care of, really sick patients with really terrible diseases like status epilepticus, status asthmaticus, hemorrhagic shock, et cetera, and that might not always be familiar with the intricacies of taking care of those patients, and really being able to take them from where they're definitely already at now, good, and seeing if we can help them be even better or great for our sickest patients who need it. There are times when, most of the time when we're practicing medicine, being good is often good enough, and you're able to provide good care to patients. And But when you work with really, really sick patients, when seconds count, like I said, when small mistakes are magnified, there's times where being good isn't enough, and you really need to be great to be able to help your patient have a favorable outcome. So something that happened recently, I had a patient come in who was extremely sick, decompensated diabetes. His blood sugar was in the 30s. Initially, people thought he had DKA, and then on further evaluation with ultrasound, etc., we noticed that he had a pretty significant pericardial effusion. And, a few minutes after that, the patient went into cardiac arrest. So it was pretty clear that, either his effusion was going to get drained right there, right now, with nobody who, drains pericardial effusion is in their day-to-day practice, or the patient was going to pass away. So, you do the best you can. You look at you look quickly at what you need to do. You refamiliarize yourself with the procedure, and within 2 minutes, while you're putting a pericardial drain in, and fortunately enough, I managed to drain the patient's pericardial effusion. We got ROSC, and the patient came out a bit neuro intact with a favorable outcome. What I'm really excited about is procedures. So like I was saying, that patient that needed a pericardial drain in not, in 20 minutes, he needed it in right then and there. So what we're hoping with the new procedures is giving people a really user-friendly environment where they're going to be able to quickly review procedures that they might not be familiar with doing, and that they'll have to do often, unfortunately, under a certain amount of stress. And really our goal is to make it as simple as possible, as easy to follow as possible, so that, when people are going to be doing those procedures, some of which are going to be done in really, hostile environments or in really critically ill patients, that it's simple, it's easy, it's all in one place, it's easy to find, and really helping our users provide excellent care and really help them get the best outcomes possible for their patients.